This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you very much, Arthur, for those very kind words. Apologies, first of all, for the... I had the same trouble yesterday. There are two buttons here, and I had a 50% chance of getting it right, and I got it wrong twice. So, just a few slides as a background, and I know some of you were at the talk that I gave yesterday, so sort of apologies for that, but it won't take long. First of all, most Australians, and in fact most people from America and from Europe, would prefer to die at home, and that's not what happens. Only 14% of Australians do die at home at the moment. Most of them come into our acute hospitals, and there's now good data to say that there's increasing aggressive treatment of the elderly frail. It wasn't a conspiracy, it just gradually happened. For those of you who worked in intensive care in the 80s, it just slowly happened. It just crept up on us. It wasn't something that anyone particularly wanted. And so the management of end-of-life care in hospitals is not good. We don't recognise these people, and when we do recognise them, we're not good at managing end-of-life and dying. We're very good at curing, we're very good at subspecialisation of medicine, do marvellous things, but we're not very good at managing people at the end of life. And nobody wants it. It's not really in anyone's interest. Patients, carers, doctors, nurses, and least of all the funders of our health system. It's not something any of us wanted, and it's not a conspiracy. It just sort of happened, and it's going to get worse. If you looked at 40, 50 years ago, there weren't nearly as many older people up the top of the pyramid, lots of working people and children at the bottom, and that's rapidly changing, not only in the developed world, but also in the developing world. And if you look at similar sort of diagrams as this in India and China, you'll find a similar shape. So most of the work in rapid response systems has been about allowing people to live safely, to extend their life, to prevent them dying, prevent them having cardiac arrests. But what we've overlooked in not only this initiative, but I guess in the way we run acute hospitals, is that people don't die safely. And it's really about that we're becoming more interested in how we can make things better. So the MET system has, as you all know, all of you who work in such a system, has become the surrogate dying system, which has caused a lot of frustration, and really we haven't got many answers at the moment. Because we're recognising these dying people, and we talked yesterday about Darryl Jones's excellent paper where 1/3 of all rapid response calls are for end-of-life care. That's one hell of a lot of calls of people that just aren't recognised by the system. However, we've recognised them, and the next step is to do something about it, and that's going to be difficult. So we get on to planning, and that's really what the title of my talk was. And first of all, I'll get on to local planning. The MET system, we sort of heard over the last 2 days about ways of recognising the deteriorating patient. Many ways of doing this. It probably doesn't matter, is my opinion. I think really the fact that we have a way of recognising, whether it's scores or single parameter or whatever, it just changes the culture of the hospital. And now we know that they're there. We've also got a pretty good response system now. We've cut out all of those rigid hierarchies, and we go straight to someone with the appropriate skills, experience and knowledge to bring them rapidly to the bedside so that we can treat these people better. So things have been working out pretty well for rapid response systems. It's not the case with people at the end of life, because the hospitals aren't recognising them. And when we do find them, as people who work in intensive care and other areas of the hospital, it's not really our expertise to know what to do. So it's pretty obvious that we need a different trigger. One of the problems is with the frail elderly is that they come in under existing medical specialties. So they might come in with shortness of breath into emergency, a bit of pulmonary edema on top of a bit of COPD, a bit of osteoarthritis, a bit of dementia and whatever. And so I don't know what it's like in your hospitals, but there are always arguments about who should accept this patient. Respiratory physician, cardiologist, whatever, and they're bumped around. And that is because they really haven't got a single diagnosis. They've got the sum of multiple age-related chronic conditions, given medicalised names like comorbidities. These are the natural accompaniments of ageing. That's really what they come in with. And then they get a bit of pulmonary edema, a urinary tract infection. This is the acute problem under which they get diagnostically labelled. However, that's not their problem. Their problem has as yet got no number or diagnosis apart from perhaps elderly or old age or even as they get sicker, dying. So that's one area, obviously, that we need to work on. We need to get rid of existing rigid diagnoses which don't apply to many of these people. So whatever we do, it has to be patient-centred. It has to be like the rapid response system, built around patients, not built around existing silos and empires. And it really should be earlier than a rapid response call, because by that stage, these people really are at the actual end of life by the time they've got a met criteria or other. So we need a more accurate way of recognising them. We need a more realistic way, not tied to traditional diagnoses, and the diagnosis is something like dying. So how do we do this? I really like this word frailty, and there's more and more work being done on this. However, it's being done in other silos. It's being done by social scientists, geriatricians, and other people who don't work with hospitals and clinicians. However, they're doing very good work. And there are many, many scores which define frailty, and such as gait speed, grip strength, how many steps you can go up one at a time, how long you can stand on one leg, and these sorts of things. So there are all sorts of measures. And in fact, we're actually working on this ourselves to try to develop a measure that's clinically relevant, to take the work of all the frailty people, but also then to put it into a clinical context at two of the most important areas where we encounter these people. Rapid response calls, 1/3 of all calls for dying people, and when they first arrived in the emergency department. So that's when we're starting to do our work. And this is the tool that we're working on at the moment. And you can see it's intuitive, much like the MET criteria. It's age, it's MET criteria, how acutely sick they are, chronic health status, whether they've been in hospitals previously, ICUs previously, frailty measures, and nursing home status. So we published this recently in the British Medical Journal. And for some reason it sort of attracted a lot of attention all around the world, and especially from North America, especially from the US, and there were front page headlines saying death list being developed by Australians. And this was the end of all people, because as soon as they hit this score, they were going to somehow be taken to some euthanasia centre. And so we got many, many calls, many, many interviews from many, many people. And I did, in fact, go on one talkback program from Texas. It took me a long while to understand what they were talking about, but then eventually we got into discussions, and this is like the Alan Jones of Texas, and that was very interesting. So we actually discussed, if this is the land of the free, you need to know this information. Somebody is withholding this information from you. You need to know it. So then all the callers got onto this and say, yes, why aren't we told this information? Australians know all about this. Why don't we all know? And everyone's jumping up and down and getting very excited. So this is currently being tested retrospectively, of course, just to see whether these scores are the right ones, and then we're going to prospectively do it. And that's involving several hospitals in Australia, as well as Denmark, US, UK, and other places. So we're going to try and develop a practical score, a little bit like the rapid response calling criteria, something practical that we can work with as clinicians that see these people in EDs and rapid response calls. The response obviously has to be fast, it has to be patient-centred, and it has to be appropriate. And that doesn't happen at the moment. Because even if we suspect someone's at the end of life, the response is not rapid. It goes through that same hierarchical, silo-based system, and if you're lucky, you may end up with someone from palliative care or someone more appropriate, but many people aren't lucky. So currently we've got a MET system where we have a button for concern or worried, but a lot of relatives and a lot of patients, for that matter, a lot of nursing staff suspect that what we're doing to these patients is inappropriate. But there's no button, there's no way of expressing their concern. In fact, if you're a relative and you say, look, I think they're dying, I'm not too sure whether we're doing the right thing, then you could be accused of being non-caring or wanting to gain from their will. So there's all sorts of really subtle drivers here not to talk about this issue. So I've just put up one example for the response once we do get a more accurate way of recognising. And perhaps it could be something like this, that if, for example, the rapid response team goes to someone and they see that they think that they're at the end of life, i.e. intensive care has little more to offer, then we call a 24/7 expert in this area. Now, I'm not too sure who this person would be, but I just put up there, maybe it's a palliative care nurse who's trained slightly differently to be more proactive than what they are at the moment. So they're the ones that are perhaps called. Because it may be our job to recognise these people, even that's a bit far-fetched, but I don't think it's our job then to treat the complex and time-consuming end-of-life care plan that goes after that. So maybe palliative care nurse assesses the urgency, talks to the home team, you must talk to the home team, discusses and be honest and upfront with patients and relatives, and then, after listening to their wishes, to get a program which is consistent with their wishes. Something like that. And at this point, I'll just say that the rapid response system started because the home team was interested in their organ. They were out of their depth with rapidly deteriorating people who needed skills that they didn't have. And I'd say, or I would suggest to you, that the home team also hasn't got the skills or experience, nor do they want to be involved in this area. There are very few of my colleagues who really want to find out who's at the end of life and undergo all those complex discussions. So, broader planning is also required. We've shown, as I've said many times, that the admitting team doesn't seem to be able to recognise them. And we've also changed the way that we have recognised dying. My grandfather, my first grandfather who died in 1959, and the GP saw him. And the GP was at the end of the line. Hospitals were very small without much. He was the one who says there is nothing more we can do, and he died. Hospitals became bigger, and so when people got sicker, they came into hospitals. This is before intensive care units. And so the specialist in the hospital was the one that said, we've really got nothing more to offer, and so that's the diagnosis of dying. And it subtly crept up on us working in intensive care that we're probably that person by saying intensive care has got nothing more to offer. And I don't mind that role, but then all the things that happen after that really needs to be in other people's hands. So we also need, I believe, as intensive care professions, doctors and nurses, to engage our society. I think we've been a little bit too siloed ourselves. We need to be talking to our society. We're the ones with all the technology. We're the ones that have got this image of we can keep people alive forever. I think it's really up to us to begin this societal discourse or discussion about modern medicine's fantastic, we can do great things, but ageing and dying are a normal process. I think it's really up to us to get out there more and more as a profession. So, and then what else do we need to do? This is from the recent article from the Medical Journal of Australia, public discussions, and people like the people who wrote this article really can't do that. They're sort of, they're sort of epidemiologists, and so they don't know what we can and can't do. Personal choices then are encouraged and formally stated by the family, and then we need to know if that system is available for the choice. People may not want to come into hospital, they may want to be treated at home. Treatment of the dying people in the home is not very good in Australia at the moment. It's sporadic, it's not standardised. And so we obviously then need to reorientate the current health systems and services to comply with these wishes. So these are some of the directions, and I think people with rapid response systems background can be involved in this new direction. I'll just finish by showing you one or two figures. There was a very recent article, same, Medical Journal of Australia, Community Palliative Care, full support in the home, for 3 months, last 3 months of life, $6,000. And we spend $3,000 per patient per day. So you can see, and although we're not really allowed to talk about costs, because this is really about suffering in patients and their wishes, there is a cost element here. And I think that could be a driver as well. And if you think we spend a lot of money, look at these oncologists and other people. This is $93,000 per course. This is a drug used in Australia. It's not curative, it's a palliative chemotherapy. And we don't seem to have any problems spending that sort of money, and yet the carers and people at the end of their life are pretty neglected. So again, I guess the dying process is a little bit like the birthing process in the 50s and 60s. It's been medicalised. It's controlled by us. It wasn't a plan. It's not a conspiracy. But we sort of are very important movers and shakers in trying to move Australia into a better way of caring for people at the end of life. Thank you very much.